Today we're going to be covering methotrexate as a treatment for ectopic pregnancy. This is a part of the CREOG Video Project through GW OBGYN program, and my name is Lindsey Vignali. The goals of this presentation include first talking about the contraindications to methotrexate as a treatment for ectopic pregnancy, talking about the mechanism of action of methotrexate, talking a little bit about dosing and management of methotrexate for ectopic pregnancy, discussing patient counseling for using methotrexate, and then we'll close the presentation by going through 2 practice questions. Contraindications to methotrexate include an intrauterine pregnancy, hemodynamic instability. So if a patient is hypotensive, tachycardic, and has a large amount of vaginal bleeding, this would not be a patient that you should use methotrexate for. A ruptured ectopic pregnancy, patients that are breastfeeding, patients that have active pulmonary disease, active peptic ulcer disease, clinically important hepatic dysfunction, clinically important renal dysfunction, evidence of immunodeficiency, moderate to severe anemia or leukopenia, sensitivity or allergic reactions to methotrexate in the past, or an inability to participate in follow-up, as patients that use methotrexate for ectopic pregnancy have frequent and regular follow-up for an extended period of time. Contraindications for methotrexate that are relative contraindications and not absolute include embryonic cardiac activity, a high initial beta HCG, so you'll see some places quote that if the beta HCG is above 5,000, methotrexate is less likely to be effective. An ectopic pregnancy that is greater than 4 centimeters in size, and patients that refuse to accept blood transfusion. So for example, if you had somebody that used methotrexate that was unsuccessful and then had a ruptured ectopic leading to hemodynamic instability, that would be dangerous in a patient that wouldn't accept a blood transfusion. So who is an ideal candidate for methotrexate? So first and foremost, you want the patient to be hemodynamically stable. Patients, it's better if they don't have severe or persistent abdominal pain. You need to check a CMP to look at liver function and renal function, and you need the patient to have the ability to follow up regularly. So what is the mechanism of action of methotrexate? So it acts as a competitive analog for folate and blocks dihydrofolate reductase and prevents the formation of THF, which in turn inhibits purine biosynthesis. So it inhibits the ability to make DNA. Side effects for methotrexate include GI side effects, so nausea, vomiting, diarrhea, stomatitis. Patients can develop abnormal liver chemistries. You can have a dermatitis from methotrexate, and some neurologic effects of methotrexate include headaches, fatigue, and problems concentrating. One of the most common regimens that we use for methotrexate is the single-dose regimen, which is 50 milligrams per meter squared of body surface area that's given intramuscularly on day 1. You then measure the HCG level on post-treatment day 4 and day 7, and ideally you have a decrease of at least 15%. If you don't have a decrease of 15%, you can administer an additional dose, and the process of rechecking the beta HCG level starts over. If you then don't have a decrease of 15%, you then would recommend surgical management. There's also a 2-dose methotrexate regimen for ectopic pregnancy where you give methotrexate the same dose as the single dose on day 1 and day 4. You measure the beta HCG levels on day 4 and 7. If the decrease is less than 15%, you can give another dose on day 7, recheck a level on day 11. If the decrease is less than 15%, you then give another dose on day 11 and check to see if there's a decrease of at least 15% between day 11 and 14. And if after 4 doses, the beta-HCG level does not decrease by at least 15%, you would then recommend surgical management. There's a third way to do the methotrexate, that is the fixed multiple dose methotrexate regimen, where you give methotrexate 1 mg per kg IM on days 1, 3, 5, and 7. You alternate with folinic acid 0.1 mg per kg on days 2, 4, 6, and 8. You measure the HCG level on the days that you're giving the methotrexate. You continue until the beta-HCG has decreased by 15% from previous measurement. Now we're going to do 2 practice questions to put our knowledge to use. You have a 28-year-old G2P1001 woman who presents at 6 weeks gestation by her LNP, complaining of abdominal pain and vaginal spotting. Her beta-HCG level is 2,500. Her last delivery was 18 months ago, and she is still breastfeeding. On ultrasound, an ectopic pregnancy is identified in the right adnexa. Which of the following is contraindication to receiving methotrexate? A, abdominal pain. B, a beta-HCG level that is greater than 1,500. C, breastfeeding. D, recent delivery. Or E, vaginal spotting. Going through the answer choices, the only strict contraindication to methotrexate that is listed in the vignette is breastfeeding. B is trying to get at, do you know the relative contraindication to methotrexate, or at what level is methotrexate thought to be less effective? And it's actually 5,000, not 1,500. Ideally, patients that are given methotrexate, you don't want them to be people who are having a large amount of vaginal bleeding or abdominal pain. So that's what A and E is getting at. But again, abdominal pain or vaginal bleeding are not strict contraindications to using methotrexate. The next practice question is a 31-year-old G3P2002 woman with an LNP of 7 weeks. She was diagnosed with an ectopic by ultrasound that showed a gestational sac with a visible yolk sac in the right adnexa. She denies vaginal bleeding and abdominal pain. She elects for medical management with methotrexate. Which of the following is appropriate counseling advice for the patient after she receives methotrexate? A, avoid cold exposure. B, avoid sun exposure. C, contraception is contraindicated after methotrexate administration. D, immediate pregnancy after methotrexate administration is recommended. Or E, increase the amount of folic acid consumption in their diet. The correct answer is avoid sun exposure. This question is trying to get at the fact that methotrexate can cause dermatitis, and counseling should include avoiding pregnancy until the beta-HCG is at a pre-pregnancy level, avoiding sun, and avoiding food with a large amount of folinic acid. Counseling that you should consider discussing with your patient should include the possible side effects of methotrexate, one of which is GI side effects, avoiding the sun, avoiding getting pregnant, as methotrexate is teratogenic. 2, counseling patients that even if you use methotrexate, they still may need surgery if they do not respond appropriately to the methotrexate. You should also counsel the patient on the frequent follow-up that is required for medical management of an ectopic pregnancy. So patients will need to come for frequent beta-HCG lab draws. And, they need to, even after they have an appropriate decrease, they will need to continue getting beta-HCG lab draws every single week until they're down to a pre-pregnancy level. These are the references and resources that I used to create this presentation. And good luck studying.